All right, thank you. So I think this is sort of what everyone has been waiting for, an opportunity to ask some questions to people, or for me, I think I'm very interested in hearing from the audience, especially the people that are generating data for this registry, people who are entering data, and the people who are actually seeing this work. I'm going to request you to sit again. Thank you for indulging me. So we've heard a lot about the registry. We've heard about the platform and the systems that have been put into the platform to make sure that it's protecting the patient's information. We've heard about the sites that are collecting this data and how people are using it or not using it. And I'm sure we all have questions about the relevance, really. I have been happy or really interested hearing that people are actually using this work. And the theme of this session is the data working, right? Is it actually working? I will start with Sister Evelyn Esther Aturi, who is a senior nursing officer in the Mulago Intensive Care Unit. Thank you for accepting to be here today. And then I would like to invite Dr. Patience Atumanya, who's an anesthesiologist at the Uganda Cancer Institute and also is a site lead at one of the private hospitals in Kampala. Thank you for coming. Next, I would like to invite our keynote speaker, Dr. Luigi Pisani, I hope I pronounced that right, who has been gracious enough to come and be our keynote speaker today at the first Intensive Care Registry of Uganda meeting, and I hope we will see you at the subsequent ones. Thank you. Next, I would like to invite Dr. Aggrey Lubikire, who's an anesthesiologist and intensivist at the Kawempe National Women's National Referral Hospital. I hope that's the proper name. Thank you. I'd like to invite Nawakonyi, who is a graduate nurse and a long-standing registry data entrant, and also works at Lubaga Hospital. And finally, I would like to invite, I think he stepped out, Dr. Moses Ochan, right on time. Dr. Moses Ochan is, he and his team at the School of Biomedical Sciences, the Research and Ethics Committee, are the reason that this registry is present in this country, because they gave us the permission to have this registry running, and we are very grateful for that. I think your ethics committee has become a favorite. Everyone is looking for an opportunity to come there, even if sometimes they may not be able to. So these are our panelists, and I would like us to start with some clinical questions. We've heard a lot about the registry, how to enter the data, you know, what data is in there, and maybe some impact that it has had. But now I want to ask Sister Evelyn. I call her Sister Evelyn. I don't know what everyone else calls her. Call her Sister Evelyn. She works in the Mulago intensive care unit. If I can ask you one question, you did say that this helped you make some changes in the ICU. I'm curious, what have you actually changed for your patient care at the bedside? And is there any specific data that you got in the registry that caused this change? Thank you.
Thank you so much, Dr. Mary. Yeah, indeed, there's been a lot, great impact in this registry work. What I can only say, or what I can start with, I'm really blessed to be an ICU. You know, it's a government facility, and I'm blessed to have my head of department being one of the developers of the protocols and the guidelines. This was key for the beginning part of it. So when registry came in, we already had protocols and guidelines on ground. It was strengthening them. You know, science keeps changing every day with evidence-based learning. So there were some highlights. There were some things that we had to improve on that. First and foremost, I want to talk about, we have been talking about protocols, like the VAP protocol, the care, the ventilator care protocol for VAP. Initially, yes, we had this on ground, but how did this registry help us? We have the monthly audits on this, and the outcomes are really pinned on every notes board. So when I like saying mine, it's not mine alone, but when the head of unit, like when she's advocating for this, there's a lot of evidence that everyone is seeing and knowing the reason as to why she wants this in place. So we have seen good outcomes on this because we have used the bundle. We have really shown the outcomes, the number of patients that have improved using it, what were the death rates, and how best was this done, you understand? So this all is attributed to the efforts of the registry that has made emphasis on this kind of care. When you look at in most of the studies, we have seen use of antibiotics. And being a government facility, you know, most of the time is in critical kind of management. But with specifically this study, which emphasizes on maybe culture and sensitivity for use of antibiotics, the high-level antibiotic use, like those high-level antibiotics, has reduced because now most of our patients, we are managing them based on the results. So we have seen the burden of resistance reduce in this because we really use the right drug for the patient. That is one of the outcomes. Now, when we look at still in our studies, we are seeing on management of patients, for instance, management of like CPR. We know very well, like most of our patients come with cardiac arrest from the ward. We have cardiac arrest from the ward to ICU for management, but there's also cardiac arrest in the wards. So we looked at most of the cases of cardiac arrest actually come from the ward. So how has the registry helped us to address this? One, it has helped us have trainings. So now we have trainings down to the wards where these patients come from. Which kind of care should they give to these patients before they transfer them to ICU posts for post-cardiac arrest care? So this has really strengthened on the knowledge gap between the lower areas. I call them lower areas like the wards, the HDUs, knowing that most of our HDU patients actually are ICU patients. Just because of space, they stay in HDU. So how are we supporting them down there before they really come to ICU if there is need? So we have seen that with this, it has reduced the number of patients coming from down because people are able to handle these patients. Then also in ICU itself, it has also helped us on management. So this has given us numbers. How many cases have we gotten of cardiac arrest? How did we manage them? Then what was the outcome within the 72 hours? Like, did they die? Did they make it? If they didn't, what went wrong is the question. And we address that. It is because of the registry that has also brought that. Then also with the burden, the registry has helped us know which cases are familiar with us. Which are these cases that come to IC? For instance, we have the neurosurgical whatever that cases. We saw all here in the presentation that more of these patients come from theater. So what has the registry helped us to do? One, to put emphasis that when you go to theater, book space. In case the patient will need ICU, will come to ICU with assurance there's this space. Even if the patient will not need ICU care, maybe will be extubated and patient is doing well and taken to the ward, that will be a good part. But basing on that, seeing that many patients come from theater, we really emphasize on that. That was brought with the knowledge that we got from our data as presented here. And as also we entered, we saw that. Then also for planning purposes, now as I said, the burden of neurosurgical cases. This has also helped the ICU, like in decision makers with our leaders. Who are these people? The personnel that is needed in the ICU. We have looked at numbers. We're blessed to have Nakasero presented having 57 staff on 12 beds. But you see with the public ICUs is the opposite. What does this translate? It means that we need to have the right numbers. The ratios should be the best in order to have the best care for this patient. That is advocacy, which is also going on with the ICU of Mulago. Then also the right personnel to be appointed, or the right personnel to be involved in the care of this patient. A question was thrown, who is taking care of these people? Don't worry, they are trained people, either on job or by course, but they have the knowledge to handle. But we are looking at it to specialty to have the best of our care.
Can also talk to colleagues. Sounds like G is doing a lot. I guess what the bit but not thought was going to happen in the first year, right? Yeah. So thank you so much. This microphone is doing. Right. It's okay, keep it. So now I want to move to Dr. Again on the clinical question. Dr. Lubikire is an obstetric intensive. Registry was created a general ICU registry, and you work in an obstetric ICU. Does this registry serve your purposes? Or do you think that your patients are lost in the maze?
Thank you so much, Dr. Mary and my fellow panelists. The registry serves us partially because some of the studies that have been done, like the Motivate study, some of the patients were already in ICU, the mechanical ventilation. The outcome that actually Cornelius talks about speaks to us. But in totality, it is speaking to us in general terms, not in specifics, because the patients we are working with are unique in that most of them are young. Their problems are either going to obstetrics or anesthesia, or both. When they come, also they stay slightly shorter compared to other general population, and they tend to recover also faster. So some of the information cannot be just extrapolated directly. It's not a copy and paste. You have to understand and say what is so special about these people. So if you do a subgroup analysis, then you come to appreciate and directly speaks to that, because then you realize, okay, out of this outcome, there are these special people. So where the gaps are is the information needs to be tailored to the pattern period. when we get some of the patients in our ICU, we worry where they're coming from, because the outcome directly tells you. When someone tells you, I'm traveling from Karamoja to Kawempe, it's not the same as someone coming from Kakisenyi to Kawempe, because transporting a critically ill has a bearing on the outcome. So you start wondering. So for us, we have dashboards where we want to know where our patients are coming from, but also how old they are, how long have they been in a hospital setting with something has just happened, then what are their other challenges. So many things contribute to mortality in obstetrics, but when you look at a general registry, they may not come out because they'll be lost in the maze. And then we've had, the last October, we went around the country finding out why were mothers dying because of obstetric anesthesia. And that information actually somehow doesn't come out in this kind of registry. So it will be very good actually when the registry, I think, is kind of tailored to this subgroup of population that have their own challenges, but also have their uniqueness in terms of data. And it's also easier to drive policies, especially if you're talking about obstetrics. The country is invested. Every mortality is audited immediately within 72 hours. And the Office of the President is highly interested. And so you find that if you're going to use policy-driven data, it is easy actually. If one mother dies and everyone is concerned, it's easier and to influence policy, but along the way you also improve information that affects outcome, both of the mother and of the neonate as well, because the two go concurrently in terms of outcome. So there is some progress, but I think there's more room for improvement.
So what I'm hearing from Dr. Aggrey is his patients are there in the registry. You have to do a specific analysis to see what's actually going on. And I think he's made some suggestions of things that he wishes he could have. I hope the registry leads have had this. Where are the patients coming from? How long have they been in hospital before they come? And I think
the kind of anesthesia they've had.
And the perioperative factors. Thank you very much. Now, I'd like to turn to Sister Nawakonyi. You've been a long-standing data entrant for the registry. What does that data look like? What does the registry look like from where you sit? And does it look like it matters?
Okay, thank you so much. To us, registry, we use it as a monitor. We look at it as a monitoring tool in improving the patient care quality and also identifying the gaps in management of the patients. Yes, and it really matters a lot. It really matters a lot because it reflects the real ICU experience. Yes.
Thank you very much. And I think those things have been reiterated throughout the different presentations from the different sites. Everyone is appreciating that the monitoring bit is important and it's actually helping them see their local data. People are pulling their own local data and using it to improve change. So that's good to hear. Thank you. Yes.
Maybe to the registry team, one thing should be captured. There is something missing in our data, like the reasons for referral, as in when we are referring a patient to another facility. Yeah, I think it will be of importance when it is included.
Reason for referral.
Yes.
Thank you very much. Okay. This is very good feedback. So now let's talk about the governance for the registry. And at this point, I would like to turn to Dr. Ochan. So this intensive care registry of Uganda is operating under a registry ethical approval. But we've also had all the studies that have been conducted and the residents research that's going on. And these proposals and projects have had to get their own research approvals from either their sites or from the School of Medicine ethics approval. If you think about it, those are two different ethical frameworks, and each of them is serving a different purpose. The registry is growing. We saw they started with a few ICUs. Now we're at 25 sites. We're going to get more and more ideas on how we can use it. So I think that architecture of the ethics, we all need to understand it. Everyone who wants to use the data, the site leads, the people who want to use this data to do their different projects, we all need to understand that architecture. And as we do more and more work out of it, I think this is going to evolve. But I think the one fundamental question that I want to ask is, this registry is really a collection of data that we get out of routine patient care, right? And it was, by the time it was started, we had Ministry of Health approval. And if you think about it, this is not human research in the typical sense of human research. So do we really need to get research and ethics approval for it? Thank you.
Thank you, but these are quite a number of questions. You'll keep reminding me if I forget some.
It's okay.
Yes, thank you so much, and thank you the team that has organized this conference. It's timely, creates awareness and information. The first question is, are these two ethics pathways or two different ethics frameworks? And the question is, the registration of the registry or its approval, and then the individual studies that utilize the data in the registry.
Yes, what is the difference between the registry approval that the School of Biomedical Sciences provided and the research approval that everyone else who has to conduct research needs to get?
Thank you. So there are two ways of looking at it. Maybe there could be the others, but this is how you can quickly categorize them. One is the one that you describe as a quality improvement process. The institution or the hospital opens up a registry as a process of improving quality of care for its patients, not for research. You just open it, to take care of your data and use it to improve your system, so your quality of care to the patient. In that way, it's not a research, and so you don't need ethics approval. All you need is to use the institutional mechanisms. If they are there, institutional frameworks. You have, for example, a privacy officer or a office that specifically would handle issues that would arise with having a registry, really to protect the participants, their privacy, their confidentiality, and the well-being, really the issues around the ethical handling of this data. If you can assure protection of that information, that can be protected well, or there is an officer that can review the frameworks or infrastructure that can enable that, then using the institutional systems, you can open this registry. However, if you're opening it as a research, like most of the registries we've had in the country so far, like the Kampala Cancer Registry, it started under research, and therefore it was registered as a cohort. And if it is registered as a research, therefore you have to be getting annual renewals of that approval until such a time when maybe you don't need it anymore. But that registry was started at the Department of Pathology, and then I think the leadership is changing And now also Cancer Institute has started its own. So the two different forms are registering it as a research, in which case you need to have a formal ethics approval for opening such a registry, and its data is used for research purposes. Even the other one, if opened the other way, still you can use it for research. But now that takes you to the second question. So the first framework does not need ethics approval because it's not a study. But if anyone has to use that data, then that person has to get ethics approval for the studies that are going to be used on that data. So individual studies that are going to be written, the residents, when you're developing your proposal, you don't go straight away and start accessing participant data. You get it? So now your proposal needs to undergo a full ethics review mechanisms of the country. And I think briefly for the student research, the ethics review mechanism in the country is in such a way that, of course, the scientific review starts at the department, and then the ethics review and consideration takes place at the ethics committees, where we have, each school now has its ethics committee, and UNCSC requires that you really stick to the committee of your institution or your school. But with justification, you can cross, like the way you say, you want to come to School of Biomedical Science as a resident. The UNCSC does not allow you to move from School of Medicine to School of Biomedical Science. But if there is a good justification, then you can. Then the ethics committees will then submit your protocols to UNCST, and then you get general approval for masters. But for PhD, you make full submission to UNCST as well. So in summary, in terms of the question, are these different ethics regulatory frameworks? No. For the one where the registry is being registered as a research, in which case it's approved as a cohort study. But for the one where it is for improvement of quality of care as an institution, as a hospital, you don't need ethics approval for such a registry requirement. So I think I've answered this question, unless you feel like I need to throw more light.
Yeah, you've answered it appropriately. I'm saving one more question for you, but
All
I will move. I will move to someone else for now. Thank you very much. So, Dr. Pisani, registries internationally tend to sit in varying ethical and regulatory environments. Some of them require full ethical approvals, while some run purely as clinical governance instruments. What have you seen work well, and what goes wrong when the ethical frameworks around a registry are not clear?
Thank you, Mary. That's a slippery kind of ground, and I'm not a regulatory person, but I can give you some numbers. So when in the GRID survey, we asked, how many of these 35 countries asked consent to collect registry data? Only 30% of the countries said we ask for consent, and the remaining 70 said we have a waiver of consent. But I think this is going to change quickly. And this is one matter. This is written consent for registry data. For ethics approval, we didn't even ask the question, because we are moving now into you need approval for any data that you collect. So all of these countries do have some kind of approval, because most of the registry data at some point will be used for research. So the registries that are limited to pure quality improvement, I don't know one. That a registry that doesn't at a certain point want to publish their data and go into changing policy. Coming to your second question, I can give a very clear example. So the Italian registry, this year, they got all their publications blocked due to one privacy officer, data protection officer from one institution, one big research institution, which is the institution owning the registry, in Italy, but the DPO, Data Protection Officer, he said that the legislation behind the approvals, not behind the approvals, but behind the consent forms were unclear. And the Italian registry has one person working, like here with Alice, only focusing on approvals for the hospital. Such is the complexity. But one DPO was able to block the publication of data for the entire country, and we now have 6, 7 manuscripts blocked. So this is one example of what can go wrong, because the Italian registry, they did acknowledge that they did not extremely clarify what was the framework they were using to collect their data. At a certain point, they do have approvals from each site, but they don't have informed consent from each patient, and they don't have it for all their periods. So this was a little bit unclear. So the suggestion is, it really is different country to country. You really have to sit down with your ethics committee, with your ministries, because ethics committees, they don't understand applications for registries. Why would they? I mean, it's not retrospective, it's not prospective, it goes on forever. It's really complicated for an ethics committee. So it must be discussed, you know, how do you want us to do this? Do you want consent? Okay, if you want consent, then we have to sit down with the ICRU team and decide how are we going to collect single patient consent for this. And now Italy, they said, we have enough. We are going to collect consent, and we close this thing. So now I am collecting individual patient consent signed by the family member for each patient. And for many, of course, we forget, because the clinician, he doesn't know even about the existence of the registry, and what will happen to those patients without a consent in a few years. So it's quite complicated, but you have to deal it at the individual country. Yeah.
Thank you very much. That's very good to know. Because we are talking about the people that are coming up to take over the registry, I'm hoping it will go on and on. There's no shortcuts here. I know we like to take shortcuts. It's best to get everything right. Otherwise, all the work that has been done is going to go to no use. Okay, so now I think everyone is thinking, where do we go from here? Obviously, we've heard about some changes that have been made. We've heard about the governance of the registry, but what are the next steps? What do they look like? And so I want to go to Dr. Atumanya. I think you've been hearing Atumanya in the study by Atumanya. This is the Atumanya. This is the Atumanya that everyone has been talking about. So you've been in the ICU space for some time now, and you have had everything that has been produced out of the registry. But looking forward, where do you think the ICU registry needs to go in the next 3 years? And is there something that you think they need to do going forward that they're not doing now?
Thank you, Mary. So looking forward to where we are going, the ICU registry has really been instrumental in getting us data from where we started up to now. And I think now we need to translate the data into clinical care processes and also advocacy. I would think one of the things we can start with is try to get the hospitals to take some kind of responsibility for the registry. In case we don't get, say, a grant in the next 3 years, we need this to continue, to have some form of, self-sustainability. We could start these discussions with the hospitals that are participating to at least maybe provide the same incentives we are giving to data entrants, so that the registry can continue. Yes. That would be one way to do it. And then 2, we could start also looking at translating it into policies. So we can start by talking to the ministries that are, I know they are rolling out a lot of health management information systems, and most of the data is getting into, going electronic. this would be one way to try and advocate and make sure that the way we collect our data stays as a national kind of guideline or SOP really. And this would enable us to use the data to advocate for funding for ICUs, funding for human resource, so that the Mulago National Referral can have a one-to-one nursing based on what the data we collected from in the registry. And this can also help us to formulate national guidelines, policies, and we can also use the registry as a checkpoint to see who's adhering to these policies, who's adhering to the protocols, so that we can make our care processes much better. And I guess the long-term benefit is to make sure that our patients benefit from this by having the higher survival rate. I forget the second question you asked.
Is there anything you think that the registry should be doing that it's not? Something that they can work on in the next 3 years? If you can, maybe to even tailor it to the bedside, right? Is that something that that would help the care provider at the patient bedside that's not in the registry now?
I think we've had quite a bit from the different units. They are using the data to actually improve their care processes. One person says they no longer have a lot of VAP. Other people know how to book beds because of the high number of post-operative patients. I think now moving forward, we could find a way to have maybe meetings from the different centers so that we can create guidelines and protocols for these units. I think that would be a big stepping stone for these ICUs that we're working in, so that we have something that is formulated based on our local data that we have, and that would make our care much better. And two, I think if we can have the subgroups also get a bit more representation. I come from oncology. I'm guessing once we start having ICUs, I would want to see what data is available, and then we can use that to also improve starting up. Same as I think Aggrey mentioned this, the obstetrics, the pediatrics, and I think if we can have these subgroups more represented and more out there, that would help us get a bit more representation from the same registry that we already have.
All right, thank you so much. I guess now this is a call to anyone in this room that works in an ICU that's not in the registry. I think it's your responsibility to go back and tell your unit lead or hospital lead that they need to get on here, because that's what's going to help build the small numbers and improve the data for the subgroup analysis. So now I want to turn to the audience and hear some comments, some questions to this panel or from your experience. I need someone to help me move the microphone around. Do I see any? Does anyone want to make any comments? Where? Yes, Dr. Jen. Dr. Jen is the head of the intensive care unit at Mulago National Referral Hospital.
Yes, thank you very much, everyone, for this very wonderful meeting. I think one of the comments I would like to make is our responsibility as critical care healthcare workers. I think we want to keep abreast of the best critical care practices wherever, whether it's high income setting or low income setting, just so we get the best outcomes for our patients. So we work in public, we work in private, but we don't usually do things because certain resources are lacking. For example, you don't sedate because you don't have sedatives. No, it's intentional not to sedate whoever doesn't need sedation. I think such things should be intentional practices. So what we get out of this data, like the Motivate ICU, it really was very key in showing that patients who are on spontaneous breathing had way better outcomes than those who are heavily sedated. So we try to push for whatever it is that is positive in what we are finding. And we encourage other ICUs to do the same.
Thank you very much for your comment. I want to make a personal comment. I have really enjoyed this meeting because everything that is shared, everyone in the room is really invested in what we are talking about, and everyone is learning from their data, and everyone else is hearing what the other person is doing. And I think there's a lot of introspection from people looking at what their data is showing. I saw a small percentage of people that said that they are not using their data for anything. And I feel very positive about the fact that I think everyone going from here is going to look at their data and actually do something, because everyone else is doing it and you don't want to be the only one who's not doing anything. Thank you so much. Any other comments, questions to our panelists? Can I ask? Yes, please. I'm going to pick a random person, please. I apologize if it ends up being you.
Thank you so much. Once again, I'm Goa, a nurse from Baru Regional. We have made many sorry about that. We have made mention several times that critically ill patients are found not only in ICU, but they are found in most of our units in the hospital. I want to ask whether a critically ill patient in any unit like accident and emergency, whether their data is important to us. And if it is important, is there any way we can collect it and it benefits the registry? Thank you.
Who wants to take this question? Sylvia.
Thank you, Mugoa, for that wonderful question. It is really good to include those patients from the A&E in the registry. But I think there the registry will need to employ more people to work on that. Because even right now, we still have some workload. You have to attend to the patients in the ICU. At the same time, you have to make sure that data is entered. So if we have to make a follow-up even at A&E, it would be hard for us maybe when they recruit people from A&E. But their data is needed. Thank you. And then at the end, the accident and emergency patients, they end up in ICU. After resuscitating them, they come directly to ICU. So we end up still picking their data. Thank you.
Thank you very much for your response. Okay. Very briefly, Esther.
Thank you so much, Colette. Every data matters, and you've said A&A, but I think according to the registry, it was specifically ICU this time. That's why we are not talking about other units. But if there is another study that may be requiring accident and emergencies and what this data is really necessary. But for now, it was only specifically for ICUs. Thank you.
Okay, thank you for that. That raises a very good question, and I think we are going to walk away with some answers to our questions, but we're also going to walk away with more questions, and we should keep thinking about them, and they will help us as we go forward. One last question. I'm going to. Okay. Yes, Dorothy.
Thank you. The presentations and the panelists are across the divide. You have people from the public space, from PNFPs, and from private hospitals. Now, there's a huge inequality. The person with the 57 critical care nurses may have 4-to-1 nursing, whereas a public facility will fail to even raise maybe 1-to-2 or 1-to-1. That's the standard. Is there accountability for this in the registry? Is it a confounder that is addressed in the data collection? Thank you.
Arthur, do you want to answer this question? You want to ask a question? Okay, in the meantime, can we get someone to answer this? Yes, Aggrey.
Kawempe National Referral. Since I joined, Dr. Mustafa was the only anesthesiologist. We are now 4 intensivists in the hospital. How did we reach there? It was information. How do you improve service of anesthesia? Your employee, we had to have a discussion with the head of, with the executive director about the mortalities that were happening versus the human resource. And sometimes it's that conversation that I can drive. So if you have that, actually, you need to sit down on the round table. In about 2 weeks from now, I'll be going with a team from Kawempe to help Porto set up an ICU. It only took one person to die, a VIP, and then I whispered in the commissioner's ear and said, can't it be an opportunity that where even a kingdom is, we can actually set up an ICU? And said, I think this can happen, so can you draw up a plan? And we drew up the plan over coffee, and it's now going to materialize. So sometimes the change you're looking for starts with you, like Dr. Arthur said. Be courageous enough to start the conversation, but be courageous enough to include other conversationalists in that talk. The people who have given us help are not part of the initial conversation, but it's just a corridor talk, and we've reached here. So I've been able to get now 1130 officers. I intentionally teach 2 universities, Kabale and Ositama University, with the intention of fostering knowledge, but I also recruit human resource. And literally everyone who is most of here have been taught by me. The Ositama students and Kabale students who are here. I've taught since 2017. Officially, none of the universities pays me money, but I'm intentional because I need to see a change. In the event that I fall sick, who is going to help me out of Kampala? You must be willing to see beyond the picture of this data. Like the patients that Dr. Adam presented, just imagine it was one of your next of kin. Do you think they could have survived if you are there? So the change we see should not be expected by your neighbor. We haven't reached where I want to be in Kawempe. We used Dr. Asimwe's data, which was about acute kidney injury in obstetric patients, to be able to convince UNICEF we have dialysis services in Kawempe now, 2 dialysis machines. So we are using information intentionally. And also the other thing is the executive director is so much data-driven and research-oriented, to the point that actually for them, they have even a budget for that. So it's easier for me even to sell him the idea about even our registry, because he's really convinced and he buys into that because he knows numbers speak volumes later. Thank you so much.
Thank you very much, Aggrey. Dr. Pisani.
Yeah, I think that really speaks to this question, which is quite important. I bounce it back a little bit. What is private? What is a public side? And I have the pleasure these 3 years of supervising or co-supervising Cornell. And when he drafted his survey to answer this question, his survey was never ending. And as a co-supervisor was like, wow, this is going to be a big study, only the survey on ICU characteristics. But he was right. Public-private means nothing if you don't give descriptors of what public and private means. We all know nurse to bed ratio. That's an easy one and important. 4:1, 1:1 is different. But what else? And so Cornell looked at protocols, and I really invite you to read that when it's out, because it's really dense. It's really saying where are the differences and which ones are actionable or not. Because we also know some private side might be worse than good public. And another example, because it goes back to your obstetric example. So in India, they now decided to describe their obstetric population. So they put on all the obstetric cases in the registry, and it came up to 500 patients in 4 or 5 years. And they compared these public-private, and the mortality was 2% in the private and 6% in the public. Although they had few public hospitals, but then we're, oh gosh, public is worse. No, when we looked at their Apache and SOFA scores, they were completely different. There was an issue of referral in public hospital that rose their Apache scores, and the standardized mortality was the same between private and public. We crossed the border, Bangladesh, 40% mortality. So it's really important to give a descriptor of what is in the sites. And I think you did a great job in Uganda. But now, I really love Arthur's presentation. Cornell, how are you going to take those ICU characteristics paper so dense and really get it into action and into policy? I think that's a good question to discuss.
Lots of questions coming up, and we may not go away with all the answers, but we shouldn't forget those questions because they'll help us to think about solutions going forward. So I want to pose one last question to each of our panelists, and it's the same question. We'll start here and go that way. And what is the one thing you would change about the registry? One sentence. Try, please.
Okay. To me, I think I got most interested in the registry, but I cited what I would change that is in the registry in my unit, in order not to miss out any information. I looked at electronic entry of patients, like registering patients electronically, which like maybe when they are code them numbers to gives them move to like get other services in the hospital. That will help data entrance get really information easily. Because when we're just entering manually, there are some things that are missed out, and this complicates data collection. So thank you.
Oh, sorry. So you're saying the hospital should get an electronic?
Yeah.
Okay. Thank you very much.
What would I change? I think I would try to have red flags pop up per site, so they can trigger these hospitals to kind of do better.
Okay, thank you. Interesting.
Can I be provocative?
Yes.
Is it allowed?
Yes, yes.
Okay, it's all mine. I'll quote a friend and a colleague. It's Abby. Once she gave me this advice when I was blocked. One thing I would change, I would forget the registry. Mm-hmm. When it doesn't help the registry narrative, forget it. I would even change the name. You know, they did this in the Nepal registry. That is also our brother in the network. They didn't call it the Nepal registry, so the intensive care Nepal registry. They call it the Nepal Research Foundation. So if you call it, you know, intensive care registry of Uganda, people in the ethics, they will start saying, what is this? Even my professor in Bari, he still struggles when I explain him, why did I take 3 days to come here? What is again this registry? But if you say, you know, the intensive care research of Uganda, because you do trials, you do quality improvement, the registry is just a tool. You do massive things. It's just a provocation, but it's when the registry narrative doesn't help, forget about it. You're answering a research question. You're doing a quality improvement project. You're doing implementation research. You're doing advocacy and policy. The registry is just a tool. You don't need to mention it all the time.
Yeah, that's a good one. Thank you.
I'll do many things, but I'll speak one like the question was.
One sentence.
I'll definitely make request that we have a mandatory module for obstetrics across the country. It is one measure of output for hospital work, especially those of us who work in government. Surgical output, especially obstetrics, is a big measure. And in this tool, I would want to understand the surgical neonatal outcomes, the mode of anesthesia given. But I would also intentionally embed a tool that does a follow-up of our patients out of ICU, like the Frog ICU study that's going on, or that was on at some point, where French and other European studies decided to follow up these ICU patients for 1 year. Because when we discharge, what will happen in the community? We have a 43, we have an 18-year-old that was referred to us from Kisenyi. She's been with us. She was referred because of total spinal anesthesia plus a cardiac arrest. She's in that ghost state where she's almost about 6 out of 8. We've been with her 45 days, and we are struggling to send at other public hospitals, which are government, because of the neurological outcome. And so you imagine those that have been out of ICU, what really happens to them. Her child is alive, she's 18 years old, but with neurological injury. And I'm wondering how many other mothers really could be in this situation and we do not know what really happens to them. Can government set up a rehabilitation center if we have this data-driven information so that we have something for them? It's a question to all of us. And also probably, do we need a commissioner for anesthesia and critical care services?
Bias true, but yes, we definitely need one. Yes, Sylvia. Thank you,
Okay.
Aggrey.
On my side, I would make the registry more user-friendly, probably to everyone in our unit, and that's the department at large. Thank you.
I think that's something that has to be picked at to understand what user-friendly means. Thank you very much.
Yeah, probably I'll not use one sentence, but recently there has been a problem with laboratory data. So when you send your patients for microbiology, culture and sensitivity tests, the patient does the test and goes away. People later won't come and they want to use the remaining samples and presented a problem. The patient did not give the sample for research, gave the sample for clinical care. So now how are you going to get that work ethically approved? It presented a problem. So I think the Ministry of Health started to improve the sample collection forms. There is now somewhere down there in the new forms that NMET is submitting for patients to consent. Just a simple sentence and 2 tick boxes that in case they would allow any of the remaining samples to be used in research. So what am I coming to? That for the data in our registry, we need to protect the owners of that data better. We need to protect them. It shouldn't be accessed by anyone at any time. That data is an individual. Okay, you have in the registry, but it's representing a person. So to ensure that the privacy of that person is ensured, the confidentiality, who is accessing this data? What are the regulatory frameworks for accessing this data? And what about the usage of the data? How are you going to use it when you access it? So I think we need to work on those issues, improving protection of the owners of this data, so that then when researchers come on these databases or in this data registry, we don't get challenges that you've had been talked about. The infrastructure of a data privacy or a privacy officer, I don't think there is any institution in Uganda that has a privacy officer. Is there any? Mulago has, eh? I don't know if there is any institution that has a privacy officer. So this becomes a structural problem in our context. The other thing I wanted to say is that UNCSC introduced a guideline in 2021, I think late 2021. My friend there can help me. There were these issues of, again, the same issue that you collect samples, and CPHL was a big culprit on this. CPHL collects samples in the entire country for HIV tests, TB, and there's a lot of samples in there. And now they want to start publishing, using those samples to do additional tests and publish work. So they were writing a big grant, and then I just stopped them, and they lost the grant because they say now, so who are the owners of the samples? So UNCSC passed the guideline in 2021. In as much as you have the patient sample collected for clinical care, and you have it in your storage, from September 2021 moving forward, that sample, you can only use it when you have tried to look for the owner of that sample and consented them. And you have to provide evidence that you failed to find that person. But the guideline is that from 2021 moving forward, September, any sample that you're going to find that someone left behind, a clinical sample, now you want to do research on it, you have to provide evidence that you have looked for that person and you have failed to get them. That's then when you can go ahead and use it. So my one sentence is that, since I'm from the ethics side, that we want to, as we collect this data, also improve the protection of the owners of the sample. Let's respect this data. This data is an individual, and we need to ensure that they are taken as that. And then maybe lastly, the ministry has a DHIS2 database. I think we know it. It's just a complicated thing, but in case the issue of sustainability, you can also explore that to see if there could be addenda to the DHIS2 database to see how to interface this data and collect it through the normal hospital data collection system for the issues of sustainability. But that is at the, if everything fails, there is a DHIS2 database system which is running in all the hospitals in the country. Thank you.
Thank you so much, Dr. Ochan. Can you join me to give a thunderous clap to our panelists? Thank you for sharing your experiences, your insights, and a lot of advice. I think the ethics person has really made us think about things that we need to think about. And I have a follow-up question that I'll follow him after this. So, so at this point, I want to say thank you to all of us. Thank you all for coming to this meeting. I want to say we've got some answers. I think there's a lot of motivation now, and we've got some questions to ponder on going forward. I want to thank everyone who's playing their roles in this registry. I want to thank the Critical Care for Asia Africa Network for putting this, building this registry network. I want to thank the local leads, Adam, Cornell, and Arthur, and your team. And then I want to thank Alice and Brian, who have organized a very good conference. Everyone is saying it has been very well organized. So congratulations and thank you for that. And I think everyone is looking forward to what is coming from this registry. And for me, I think once this is out there and people are hearing about it, everyone is going to want to do better in terms of collecting data and collecting good data. So some announcements. Please scan the QR code on your badge for the post-conference survey. I hope they will get more than 25 responses this time. There's a dinner at the pool starting at 6 for the registry network members. And then for the registry network members, tomorrow's meeting, the dress code is anything that allows physical activity. So at this point, I'd like to invite, we're going to have a group photo. Please don't go away. But first, I think we should take a picture of the panelists with the local registry leads and the team support. Herbert, Alice, Brian, please come up for photo. Cornell, Adam. And then we'll take a group photo of everyone in the room. Davis, we need your help.